On one side of the medical world, you have um, this devastating surgical crisis involving synthetic mesh.
Hmm.
It's left thousands of women in just excruciating chronic pain.
Right.
But then on the other side, you have a controversial, totally headline-grabbing regenerative wellness treatment, something that's been popularized as the orgasm shot.
Which is quite the pivot.
It really is. And today, we are looking at the exact biological moment where these two wildly different worlds collide. So, welcome to the deep dive. For you listening right now, our mission today is to explore how a trademarked sexual wellness protocol is currently being investigated as a life-changing solution for severe surgical complications.
And honestly, it sounds absurd on its face, right? I mean, we're talking about bridging severe surgical trauma with basically regenerative aesthetics. But the underlying cellular biology that connects them is just remarkable.
Yeah, and to map out that biology, we are pulling from a massive, highly specific stack of sources today. We're looking at clinical data from medical journals like MDPI and Obstetrics and Gynecology.
Oh, the Green Journal, yeah.
Exactly. Plus, we've got patient decision aids from NICE and the NHS, some really incredible ground-level reporting from The Guardian, and even press releases straight from PR Newswire. But I think we have to start with the sheer scale of the original problem, because the severity of the mesh disaster really dictates why this super unconventional treatment is even being considered in the first place.
Yeah, the historical context is vital here, because for decades, implanting synthetic pelvic mesh was just the undisputed gold standard for treating stress, urinary incontinence, and pelvic organ prolapse.
Like it was just what you did.
Exactly. Surgeons would implant this plastic material to essentially hammock the organs. They were relying on the body's natural response to foreign material to build support. The medical community was, essentially treating the pelvic floor like it was an abdominal hernia.
Right, and I was reading through the source material, specifically the work of Dr. Abbas Shoberi, who's this expert in urogynecology.
Yeah.
And he highlights this really fundamental, almost catastrophic misunderstanding of the tissue involved.
Oh, the mouth analogy.
Yes, it's so visceral. He points out that the vagina is not a static abdominal wall. It's this highly innervated, dynamic organ. It's constantly expanding and contracting. So he makes this vivid comparison. He asks you to imagine an oral surgeon placing a stiff, contracting piece of plastic mesh inside the soft tissue of your cheek, right next to the trigeminal nerve.
I mean, the resulting agony would be instant. The mechanical friction alone would just be intolerable.
Totally.
And what's fascinating here is the body's response. When you place a rigid, shrinking piece of plastic into the dynamic space of the female pelvis, the body recognizes it as a persistent invader.
So it fights it.
Exactly. It triggers a massive, localized foreign body response. The immune system attacks the mesh, which generates all this chronic inflammation. And over time, the body tries to wall off the invader by forming really dense, rigid scar tissue through every single pore of the mesh.
Which is horrifying to think about. And reading the first Do No Harm report out of the UK, it just puts this harrowing human face on that biological process.
Yeah.
I mean, we are looking at women dealing with chronic pelvic and leg pain that is so severe they require opioids just to sit down.
Yeah, just to sit.
And there are cases of the mesh eroding and literally slicing through the vaginal wall or perforating into the bladder and the bowel. The complication list from the sources is just relentless. Recurrent antibiotic-resistant infections, severe dyspareunia, autoimmune cascades.
And the structural damage often leads to severe nerve entrapment. There are documented cases of women confined to wheelchairs.
Oh my God.
Solely because the contracting mesh and that resulting fibrotic tissue we talked about have essentially strangled the major nerves of the pelvis.
I was looking at the NICE patient decision aids, and my first thought was, okay, if this toxic plastic is causing so much systemic and local damage, why is surgical removal treated as an absolute last resort? Why not just take it out immediately?
Because taking it out is not like pulling a splinter. Remember that dense, fibrous scar tissue? The tissue and the mesh become deeply, inextricably intertwined. The mesh is practically embedded within the host tissue at that point.
Right. The surgical options for removal, they're categorized as either partial or complete. And both of them read like high-risks salvage operations rather than clean extractions.
They absolutely are salvage operations. Removing the mesh requires a surgeon to meticulously dissect through highly vascularized, deeply scarred tissue. They're operating millimeter by millimeter in a heavily compromised field, and they're navigating directly against the bladder, the bowel, and those major nerve bundles.
So one slip in?
The risk of collateral damage is exceptionally high.
Yeah, the 9A's documents state unequivocally that excision surgery might not even improve the symptoms, and it frequently causes worse complications. We're talking about severe hemorrhage, permanent nerve transection, or, accidentally tearing the bowel. Some women go in to have the mesh removed and wake up needing a permanent stoma because their bowel had to be diverted. Or they develop a complex fistula.
And beyond those catastrophic surgical risks, there's a functional catch-22.
What do you mean?
Well, if the excision surgery goes perfectly, say the mesh is completely removed without complication, the structural support it was providing goes with it. So the original severe incontinence or the prolapse often returns immediately. Patients are trapped. They have to choose between living with a deteriorating foreign body or risking a life-altering excision surgery that could leave them with permanent organ damage.
Wow. So if excision surgery is just a non-starter for many patients because of that dense scarred tissue, surgeons had to figure out how to heal the tissue without cutting it.
Exactly.
And that meant looking at treatments that force the body to regenerate its own vascular network. Which brings us to platelet-rich plasma, or PRP.
Yeah, PRP. It's an autologous treatment, meaning it utilizes the patient's own biological material. So blood is drawn, processed in a centrifuge, and the concentrated platelets are extracted from all the rest of the blood components.
And there was this reporter from The Guardian who was observing this exact process. They described the separated plasma as looking like dehydrated urine floating at the top of the vial.
It's a very striking visual, for sure.
It is. But then a doctor named Charles Runels took this exact PRP process and trademarked a specific protocol for female sexual wellness. He called it the O-Shot, injecting it into the clitoris and the anterior vaginal wall to improve natural lubrication and boost arousal.
Right. And the underlying premise of the O-Shot is that by concentrating the patient's platelets and delivering them directly into that local tissue, you can regenerate the microvascular and neural networks.
Okay, let's unpack this, because wait, hold on. We are talking about devastating surgical trauma, mesh eroding into organs.
Oh.
And you are bringing up an orgasm shot. I really have to push back here. Injecting blood into the clitoris for better orgasms sounds like a trendy, unproven celebrity wellness scam.
I know.
It sounds like a pure placebo. So how is there any legitimate biological leap from a branded wellness shot to treating severe surgical complications?
I completely understand the skepticism. If you only look at the consumer marketing side of it, it sounds entirely superficial. But if you strip away the branding and you just look at the cellular level, platelets are not just the inert little bricks we once thought they were, just floating around waiting to form a scab.
So what else are they doing?
Inside these platelets are these tiny structures called alpha granules, and they are densely packed with powerful signaling proteins and growth factors.
Growth factors, like what kind of growth factors are we talking about?
Vascular endothelial growth factor, or VEGF, and platelet-derived growth factor, PDGF, among several others. And when you extract these from the bloodstream, concentrate them, and inject them into damaged tissue, they act as this massive, localized signaling beacon. They stimulate a process called angiogenesis.
Angiogenesis. So they are forcing the body to build brand new blood vessels from pre-existing ones.
Precisely. They create new vascular networks, which floods the area with fresh oxygen and nutrients. They simultaneously trigger fibroblasts to synthesize new, healthy collagen. And they promote nerve regeneration while actively suppressing chronic inflammatory pathways. So the biology of the O-Shot isn't magic. It's fundamentally about rebooting the tissue's regenerative capacity.
Okay, and the clinical data from the sources is actually starting to back this up. Like there's a recent randomized controlled trial published in Obstetrics and Gynecology of the Green Journal, and it confirmed that PRP injections into the anterior vaginal wall significantly improve sexual function scores compared to a control group.
They do, though there is a critical nuance in how that data is interpreted. The media frequently uses the term O-Shot generically, just for any vaginal PRP injection. But Dr. Runels actually issued a response via PR Newswire specifically addressing that Green Journal study.
Oh, right. I remember reading that.
Yeah, he pointed out that the researchers did not follow his strict trademarked protocol. They injected the vaginal wall, but not the clitoris, and he argued that that deviation is exactly why their recorded magnitude of improvement was smaller than what he observes in his own clinic.
But why does the exact location or the centrifuge process matter so much? Like, if you have the platelets, shouldn't they just do their job regardless of the exact injection depth?
Well, in regenerative medicine, the protocol dictates the biological outcome, period. The physics of the centrifuge determines the exact concentration of the platelets. The depth of the injection determines which layer of tissue, the mucosa, the submucosa, the muscle, actually receives the payload. It is a highly targeted biological intervention, not just a generic wash.
Okay, I see. And that targeted intervention is exactly what your gynecologists began looking at for these mesh patients. If a standardized PRP protocol can regenerate vaginal tissue and rebuild blood vessels, what happens when you deploy those alpha granules into a patient whose vaginal tissue has literally been shredded by synthetic mesh?
And this is where the clinical data becomes truly staggering. We have to look at the recent prospective study published in the International Urogynecology Journal, the one that was heavily featured in our MDPI scoping review.
Yes, let's talk about that study. So, the researchers took 47 women who were suffering from highly symptomatic vaginal mesh complications. These women had abnormal discharge, chronic pain, and physical mesh exposures.
Meaning the epithelial tissue had broken down.
Right, and the plastic mesh was actively poking through the vaginal wall into the vaginal canal. The exposures were smaller than 2 centimeters, and these women had already failed conservative treatments like localized estrogen. They were literally on the waiting list for that high-risk excision surgery we talked about.
And instead of sending them to the operating room, the researchers utilized a combination therapy. They used a fractional CO2 laser, followed immediately by localized PRP injections.
Okay, I really want to break down the mechanics of this combination, because injecting growth factors into an area that is already highly inflamed seems, it seems counterintuitive. How does the CO2 laser prepare the tissue?
So a fractional CO2 laser vaporizes tiny microscopic columns of water in the tissue. This creates thousands of microscopic thermal injuries while leaving the surrounding tissue totally intact.
Wait, so you are intentionally injuring tissue that is already traumatized by the mesh?
Yes, and that intentional microtrauma is the key. You see, the tissue surrounding exposed mesh is stagnant. It's trapped in a state of chronic low-grade inflammation. It's starved of blood flow and estrogen. It simply lacks the biological fuel to heal. So the fractional laser physically disrupts that stagnant scar tissue and forces an acute wound healing cascade.
Oh, I get it. But because it's a fractional laser, it doesn't just burn off the whole layer, and crucially, it doesn't interact with the plastic mesh itself.
Correct. The laser creates these microchannels in the surrounding scarred tissue, and these microchannels serve a dual purpose. First, they break the fibrotic barrier, and second, they act as physical delivery shafts for the PRP.
Okay, so it's less like physically patching a hole with outside material, and more like dropping a localized software update deep into the cellular matrix that just reboots their healing instructions.
That is a highly accurate way to visualize it, yes.
Yeah.
The PRP is poured into the vaginal canal and injected directly around the margins of the mesh exposure. And because the laser has created these open shafts, that massive payload of VEGF and PDGF can penetrate deeply into the compromised tissue.
Wow.
And those growth factors immediately shift the local microenvironment from chronic inflammation to aggressive proliferation.
It's like discovering you can patch a crumbling pothole from the inside out by stimulating the road to just grow its own asphalt, rather than bringing in bulldozers to tear up the entire street.
That's a great analogy.
So what were the actual results of this reboot? Because remember, these women were destined for the operating room.
Well, after 3 consecutive treatments spaced a few weeks apart, 85% of these women did not require surgical intervention.
Wait, really? 85% avoided excision surgery?
Yes, 85%. Their pain scores plummeted, their bowel and bladder function improved, their sexual function scores increased, and most remarkably, upon physical examination, the tissue had completely epithelialized.
Meaning what, exactly?
Meaning the body had literally regenerated healthy, vascularized tissue over the exposed plastic mesh, reburying it safely and resolving the exposure.
That is wild. The body essentially forgave the presence of the foreign object because the local tissue was suddenly robust enough to handle it. You are empowering the host environment to resolve the trauma itself, rather than inflicting massive surgical trauma to dig out the device.
It's a profound shift in surgical philosophy. You're modifying the host's biological response rather than mechanically altering the anatomy.
So what does this all mean? As miraculous as that 85% success rate sounds, we cannot leave you with the impression that this is a guaranteed universal cure for the entire mesh disaster. The MDPI scoping review is very careful to outline the clinical realities and the strict limitations of this data.
Yeah, the limitations are significant. First off, the prospective study we discussed was small, only 47 women. But more importantly, it specifically targeted women with mesh exposures smaller than 2 centimeters.
Right, so what happens if the exposure is larger, or if the mesh has fully perforated an organ?
In those cases, PRP cannot bridge massive structural defects. If a patient has a large exposure, or if the mesh has eroded entirely through the vaginal wall and created a fistula into the bladder or the bowel, unleashing growth factors will not close that anatomical gap.
It's just too far gone.
Right. For those catastrophic large-scale failures, complex excision and reconstructive surgery remains the only viable option.
The scoping review also addresses the application of PRP for other pelvic floor issues. And while it worked brilliantly for epithelializing tissue around the mesh, the evidence shows that using PRP to treat anterior pelvic organ prolapse itself, like attempting to lift and support the prolapsed organs without using mesh, has yielded highly mixed and inconclusive results.
And that makes complete biological sense when you separate tissue regeneration from mechanical support. PRP can build new blood vessels and it can thicken the mucosa, sure, but it cannot instantly generate the dense, high tensile strength fascial tissue that's required to mechanically hold up a prolapsing bladder.
Right.
You're asking a biological signaling protein to do the job of a physical hammock. It just doesn't work that way.
The NDPI review also raises this massive red flag about the broader landscape of regenerative medicine. They describe it essentially as the Wild West. The reviewers noted severe reporting gaps across the published literature, which loops right back to Dr. Runel's frustration about strict protocols.
The reporting gaps are a huge issue. They're a critical barrier to standardizing this care. Many clinics, and astonishingly, many published clinical trials, fail to report the exact platelet concentration they achieved. They don't report the G-force or the duration of their centrifugation.
Which seems basic, like why does the G-force matter so much if you were just separating the blood?
Because platelets are incredibly delicate. If you spin them too slowly, you just don't extract enough of them from the red blood cells. But if you spin them too violently, you prematurely rupture the alpha granules in the tube rather than in the tissue.
Okay. The review also heavily criticized the lack of reported activation strategies. What does activation mean in this context?
Platelets do not simply release their growth factors just because they've been drawn into a syringe. They require a chemical trigger to degranulate. In normal human biology, that trigger is exposure to collagen during a bleeding injury. But in a clinical setting, extracting the platelets often requires the physician to add an activating agent like calcium chloride or a specific thrombin to physically crack open the platelets and release the VEGF and PDGF.
So if a clinic just spins the blood and injects it without activating it properly, they might just be injecting inert fluid that slowly washes away before the growth factors can even deploy.
Exactly. A generic PRP injection advertised at, say, a local med spa is biologically entirely different from a meticulously formulated standardized protocol delivered by a specialist.
Right.
Patients desperate for an alternative to mesh excision really must understand this distinction. They need highly specialized urogynecologists who deeply understand the complex neural anatomy of the pelvic floor and the precise physical chemistry of platelet activation.
Absolutely. So if you or someone you love is navigating the nightmare of a synthetic mesh complication, where does this leave you? The definitive takeaway from our sources today is that PRP, a regenerative technology that captured the public's attention through sexual enhancement, is emerging as a highly credible, minimally invasive alternative.
It really is.
It possesses the genuine biological capability to heal microtrauma, regenerate vascular networks, and potentially prevent the nightmare of excision surgery for a specific subset of women.
It provides a very real bridge of hope. But the mandate from the medical community is clear. We require much larger, rigorously standardized, randomized controlled trials before this can be offered as a frontline, universally accessible treatment protocol. The science must dictate the progress.
It really is a remarkable narrative arc. A biological mechanism leveraged for aesthetic and sexual wellness is now throwing a literal lifeline to patients injured by one of the most heavily litigated and poorly conceived medical devices in modern surgical history. I want to thank you so much for joining us on this highly complex, technical, and ultimately very hopeful deep dive today.
And as we conclude today's exploration, I want to leave you with one final concept to consider.
Okay.
If our own autologous blood can be harvested, concentrated, and reprogrammed to force our tissue to regenerate, essentially overriding the profound structural trauma caused by synthetic implants, what other irreversible surgical mistakes currently trapped in scar tissue might one day be resolved simply by unlocking the latent regenerative software already flowing through our veins?